Hello, welcome to session 5 of the online A to Z in dental implant therapy. This session we will discuss and review immediate tooth replacement and restorative challenges. This to me is one of the most exciting aspects of implant dentistry. It gives us the potential to really give the patient back what they've lost in the minimum amount of time with the greatest conservation of soft tissue and bone. Of course, it's also a risk. There's a risk of having really a big problem, a large defect. If we lose the implant, if we cause bone loss, if we hit an adjacent tooth, there's many issues. But like with everything, with skill, with understanding the biologic potential, we can accomplish these things, I think, in a very positive and reasonable way. Again, with like everything, the more we understand, the more we can predict, the more we visualize the biologic potential of a case, we're able to work through them more appropriately. Now, I have some material from Dr. John Coyce, who really 6-7 years ago was looking at these issues, and I'd like to share with you some of the things that he was showing. And basically, in terms of considering immediate tooth replacement, he found 5 diagnostic keys that helped decide whether or not it was appropriate to even consider doing an immediate placement. One thing I always like to do when I have a patient, especially a tooth like this, it's a hopeless situation, it has internal resorption, but the patient may look at it and not even realize that the tooth is lost. They may look at it and see, well, it's fine, couldn't we just do a filling? The patient has to accept that the tooth will be lost. I really strongly advocate that we don't rush into removing the tooth until the patient is part of the team, that they realize what's happening, maybe they get a second opinion, whatever it takes, so that they're willing to go on with treatment and they understand the treatment that needs to be done. Is it appropriate to think about doing an immediate placement? The truth is we don't know yet, and sometimes we don't even know till the day of surgery, so there's lots of unknowns. From the moment we start treatment planning the case to the moment we extract the tooth, we're always asking ourselves if it's appropriate to continue on with that treatment. And so we'll continue here and see what some of the issues are. And here, if we look at these 5 basic issues, and let's start off maybe less favorable. What's the less favorable potential for doing an immediate replacement? If the pregingival margin of the crown is more apical than the desired end position, of course we have a lower potential for the outcome because the crown will look longer. It won't look as aesthetic or as attractive. If the gingival form is a scallop, a high scallop, so we have a big discrepancy between the peaks of the papilla to the depths of the labial position. That large scallop makes it very difficult to maintain that shape during an immediate placement. Thinner tissue, a triangular shape of tooth, and probably the biggest key for me on a biologic point of view is the position of the bone. If the bone is more than 3 millimeters away from the desired emergence profile, we can't maintain the aesthetics that we have now. As we place the implant, we will lose soft tissue and we'll end up with a longer tooth. We have to ask ourselves if that's appropriate. And also important is the position of the bone on the adjacent teeth. If the bone is more than 4 millimeters away from the desired papilla position, again, as we place our implant, we will lose tissue, probably lose some papilla, and not have as favorable a result. So kind of just to review, as we look at the case and we see that the pregingival margin is at the same, more coronal or more apical, that will affect what we decide to do with the case. We also might consider orthodontic extrusion. And we do this periodically where we begin with an apical position of the soft tissue on the natural tooth, fairly reasonable, and the tooth we're going to have to extract is already more apically positioned. So if over the next few months we could extrude that tooth, and we have to realize that we can extrude the tooth very rapidly. The point is, can we create bone in that area? Because we need bone to maintain the soft tissue profile. So we need to maintain this tooth in this position for a reasonable length of time in order to achieve the bone growth that we need to have. So before extrusion, we have a potentially poor result without significant grafting, and at least a 2-stage procedure for an adequate result. After extrusion, if we can pull the bone down with it, there is the potential for achieving a perfect aesthetic result with minimal invasion of the patient, gently removing the tooth, placing the implant immediately with an immediate provisional, and we can achieve the best possible result in the most conservative way to the patient. The gingival form, of course, a flatter scallop, is much easier to deal with just because the tissue tends to be more fibrotic, it tends to be thicker, it tends to not change very rapidly, where that thin, friable soft tissue that has a big scallop tends to be a much bigger challenge to the patient, for the restorative dentist and the surgeon to try to maintain that scallop, to try to maintain the final result. You can look at the thickness of the tissue really by slipping a perioprobe underneath the tissue, and if you can see the perioprobe, that's very thin tissue. If you can't see the probe or it feels thick or fibrotic, certainly that suggests to us that we have a better potential for that tissue staying where it is even during an immediate placement procedure. A square-shaped teeth really goes with a flatter scallop. Triangular teeth goes with a higher scallop. But the bottom line, always biologically, is where is the bone? If the bone is in a good position, we can place the implant without doing any bone grafting. If we can do that and we can achieve or maintain that perfect emergence profile, we'll have a nice result. And so we need to look at the amount of bone that we have in order to achieve that. And it's a good way to think of it. It is really the bone height on the adjacent teeth that supports the papilla for single tooth implants. If we have the bone on the right position on the natural teeth adjacent to our implant, then we should maintain the soft tissue. So now thinking of this in a more favorable tone, the free gingival margin, if it's more coronal than the adjacent teeth, we're in great shape. So even if we lose a little bit of soft tissue, we'll match perfectly on our adjacent natural teeth. We would like to see a flatter scallop, thicker tissue, squarer teeth, and we need the bone to be very close to the gingival margins. Less than 3 millimeters away from the labial position and less than 4 millimeters on the adjacent teeth. When we have that, and we can remove the tooth without damaging the bone, and we can achieve a certain amount of stability to our implant when it's placed, and do some fairly simple condensation grafting procedures around the head of the implant, make a reasonable provisional that's kept pretty much out of occlusion, we can achieve a immediate implant placement with immediate provisionalization, or what we might call immediate tooth replacement. I like to think that the primary reason today for placing an implant at the time of extraction and a provisional restoration is to support and maintain the gingival architecture of the failing tooth. Over the last 4 sessions, I made a big deal about the fact that soft tissue is totally related to the bone. Without the bone, we can't predictably have soft tissue. But I also believe it's reasonable to state that if we can maintain the soft tissue contour, if we maintain the anatomy of the soft tissue, the architecture of the connective tissue fibers, if we don't lose that, we also have a greater potential to maintain the bone in that area. So there is tremendous advantage to maintaining the gingival architecture, especially if it's in a healthy position.